This is a 3-video series: what men want at birth, what professionals want, and what women want. Men were the easiest part, honestly. You can get to tell me that I'm wrong. You want to know what to do. And really you want to know what to do from pregnancy onwards. And that's what we explained. It's all about having skills, and why so many birthing better fathers were so important to the development of the skills, because they were creating skills that they want and could use in all circumstances. Professionals in the birth field are a bit of a hard group. They're just 1 degree away from the pregnant woman. And why are they 1 degree away from the pregnant woman? Because the pregnant woman's doing the activity. She is 0 degrees away from the experience. The first tier birth workers in the medical profession are obstetricians, general practitioners, certified midwives, and direct entry midwives. In traditional health systems, rarely are there a profession of midwifery. It's most often people that you know, but in some cultures, there are women and men who specialize in birth. And that's culturally dependent. The natural birth movement wanted maternity care really to be housed under midwifery care. And in the late 70s, the conversation was really, what's a midwife? There were midwives all over the world, either traditional birth attendants, certified nurse midwives, or direct entry integrated into most maternity systems. But in the United States, people wanted midwives to sit outside of the medical system. When we ask, what do first-tiered birth professionals want in regards to the 3 childbirth goals? In the traditional system, they want a live mother. They accept that a baby may not be alive. In the medical and the natural birth movement, they would both like to have a live mother and a live baby. However, these 2 systems, modern medicine and the natural birth movement, approach this global goal number 1 differently. The medical profession basically does all the assessments, monitoring, procedures with the hope that doing those prevents the tragedies, deals with the problems if they occur, and deals with the risks so that they don't become problems. And it's a pyramid. There are lots of risks, there are fewer problems, and there are much fewer tragedies. The natural birth movement treats birth as though it's natural, acknowledging there are few tragedies. However, that's based on an assumption that few tragedies mean that there are few problems and that there are few risks. And so the medical profession treats the word natural, normal, and physiological to mean anything that might happen, could happen, so let's be overly protective. And the natural birth movement treats normal, natural, and physiological as though it's innately good. And so this is part of the conflict that we experience with this global goal number 1. How do these birth workers deal with suffering? In modern maternity care, the professionals don't want to see women suffer. So in my grandmother's life and my mother's life and in my life, pain relief has been used to reduce suffering. In my life, it shifted between one birth and the next and has now sort of settled into the epidural phase. Women demanded that they be awake, without pain, and able to participate in the birth. The natural birth movement doesn't advocate for pain relief because they see it as an intervention, which is unnecessary and imposed on women. And this is where it becomes a wee bit complex, because in the 50s, 60s, and 70s, when the natural birth movement was rising, they supported skills. They supported skills not because there was a goal of reducing suffering. The goals were to have a natural birth, pain-free labor without medical care, and that pain-free labor part of it came from Grantley Dick Reed, who was saying to people, if you're afraid of birth, you're more likely to have pain. Therefore, don't be afraid of birth, and you won't have pain. And by the 80s, the natural birth movement sort of stopped using the word pain. They shifted over to the words like rushes or waves. So it's quite difficult, even today, to understand how the natural birth movement feels about pain in birth or suffering in birth or women who aren't coping well in birth. Traditional birth workers may use some herbs, but mostly they just support a woman, and suffering is accepted because life can be hard. One note is that there are many cultures and religions around the world where women are told not to make a peep during birth, and so you don't know if they're suffering or not. In response to the global childbirth goal number 3, good recovery of the mother and the baby, short, medium, and long term, neither the medical profession or the natural birth movement pays much attention to that, whereas traditional cultures pay a lot of attention to it, and it's usually in the form of up to a 40-day exclusion of the mother and the baby from society and from work. There are other types of birth professionals, though, that are second degree from the woman. Pregnancy yoga teacher, doulas, childbirth educators, ICPA, Webster chiropractors. They'll work in pregnancy and with a family, but they're not often at the birth, although individually they can be. But they're not responsible for the birth, and that makes a big difference. We have to ask whether the second tier of birth workers are really focused on these 3 global childbirth goals: alive mother and alive baby, suffering, and recovery. In reality, the childbirth educators in the 60s and the 70s were focused on the suffering through the Lamaze and Bradley skills. But because that wasn't recognized, how successful that was, and it wasn't one of the goals, it was dismissed. And it was dismissed really to the point, as I've mentioned before, skills were dismissed as unnecessary. So in the choice-based system, suffering isn't really dealt with, even by childbirth educators. Of all of the second-tier birth workers, it's the ICPA members that are most focused on the childbirth goals. They work postnatally with women, so they know that women can be damaged from even the most natural birth, and they work with babies. They don't appear to work much with suffering during birth, but they do very strongly relate to the first childbirth goal, which is a live mother and a live baby, because the purpose of the Webster technique is for a baby to move through the woman's body more effectively. And so you reduce the risk of stuck babies, which is the primary cause prior to modern medicine of why babies and mothers died in birth, along with sepsis. I've had 50 years in this field, and it's all been both promoting the concept and working with families who are using birthing better skills that they created and I created. So I want to tell you something about our experience in the 70s, the 80s, and the 90s up until the 2000s. I immigrated to New Zealand in the mid-1990s. Midwifery model of care had been put in place in 1990. So the births that I attended in New Zealand were all midwifery-led births. So I want to tell you about my earliest experiences with families bringing self-learned skills into their birth experiences. There was this very unique time from the late 50s until the middle 70s in the United States. And you know whether this occurred in your country. As mentioned, everybody was taking the first childbirth preparation classes, which were primary Lamaze and then Bradley method. But when we talk about what professionals wanted, because they were already using pain relief, this was the first time that they saw women using skills, and fathers were coming in. So for my generation, obstetricians, general practitioners, and obstetrical nurses saw were multiple millions of us coping better. So we were dealing with the childbirth global goal number 2, suffering. We reduced our suffering by coping and managing better by using skills. In hospitals where there were Lamaze classes, and in that community where there are a large number of people coming in and using skills, mothers and fathers working together, the staff became much more relaxed. They liked their job more. They don't want to see women suffer. And so they enjoyed their job more for a generation. Multiple millions, can't say it enough, multiple millions of families my age used skills, and we reduced our suffering. We coped better. We managed better. We worked together better. And this had a positive impact on birth professionals. It had such a positive impact that birth professionals, the way things were done in hospitals, began to relax. We could get up and walk. We could eat. We could drink. They even started to bring birthing pools into hospitals. Women could take showers. It was because they saw multiple millions of skilled families. We coped not because we changed our attitude, but because we had skills, and we had a skilled birth coach to help us stay on top of both the internal sensations that we were having and be able to deal and cope with the things that were being done to and around us. Birthing better skills and this concept were just developing as the Lamaze and Bradley era was beginning to lose favor because of the new messaging that was coming through the natural birth movement. What I want to talk about now is our experience in the 70s in hospital births from the obstetricians and the obstetrical nurses. I also want to talk about my experience with midwifery-led births, both in the United States and New Zealand. In the 70s, primarily there were male obstetricians, although there were increasingly more female obstetricians. And by the end of the 70s and 80s, pregnant women who wanted more natural births were encouraged to go to female obstetricians. We found that male obstetricians were infinitely more tolerant with working with birthing better families. Because ultimately what men were saying as a doctor, if all the assessments, the monitoring, even in most complex pregnancies, because I worked with very high-risk families, if every sign in their way of monitoring was okay, they would just permit things to continue. And obstetricians, whether they're male or female, are participating in all births in all forms. Female obstetricians would often say to the woman, if this were me, I would do X, Y, and Z. And they were much more likely to want more assessments, monitoring procedures than the men were. And this was a time where women were being told to follow women and not men, that it was the male-dominated hierarchy where the problems existed. But that wasn't our experience on an individual basis. Both female and male obstetricians are trained within a system. There are male midwives, but there was a lot of pressure for it to be a woman-centric profession. How did midwives respond to birthing better families? They pretty much ignored it. They weren't advocates of women being skilled. Obstetricians didn't feel it was in their purview to encourage families to become skilled. However, they loved working with them. You would think that midwives would be the perfect profession to advocate for families becoming skilled because they have often set up both a continuity of care model and a partnership model. So you would think within that partnership, people having skills for their task that they'll be doing would be preferential for both the midwife and for the family who is giving birth. But by the 80s, midwives were actually telling women, based on famous authors, that women shouldn't be skilled in birth, that it was this natural, instinctive, innate experience that we knew how to do, and that skills put us into our thinking brain and not into our primal brain. And often when I was working with a skilled family and a midwife was present, they couldn't distinguish that someone was using skills. And often they weren't keen with fathers being the coach. And by then, women had been taught that the midwife really was their primary care provider and should rely on the midwife, which is interesting because in the standards of care in New Zealand, they give 24/7 care to pregnant women and women birthing. But they say in their guidelines that women should be left alone during the birth. So you often heard people say, I loved working with my midwife. She was there for me, but she didn't help me during the birth when I really needed her. Before I immigrated to New Zealand in the 90s, one of the things that stood out to me in all of the countries where I worked and visited was that midwives, home birth midwives, were absolutely exhausted. They wanted a partnership, they wanted continuity of care, but they were giving too much of themselves and asking too little of the families. And that's one of the things that we hope that this concept will change. Women should want to make certain that they do everything that they can to support their midwives. And becoming skilled is one of those things that they should do. Because if midwives worked with skilled families, they would be less tired and families would be less reliant on them. It doesn't mean that families don't want midwives. They do want midwives. But in my experience of attending many births and seeing many care providers, what I learned was that obstetricians don't care whether a family is skilled or not. But they loved working with skilled families. They loved it. It made their job so much easier, so much less stressful. And they never once stopped a woman or man from using skills alongside all the assessments, monitoring, and procedures. In fact, they often encouraged it. They were happy campers. And that's what H.A. Brandt in his 1961 National Women's Hospital study in New Zealand showed. They loved working with skilled women. My experience with doulas was that they rose up at a time where fathers were discouraged from being birth coaches. And first, their job was to be the birth coach as a woman. But what I also noticed very quickly, they were really taking the role of fathers. And for us, that was damaging to families. Since then, doulas have spread out into postnatal role, which is probably where they can serve the community best, because women need help during that postnatal period that all traditional cultures understood. And what about midwives? Often they want to do skills on women. They see body skills or acupuncture or reflexology or herbs or homeopathics as natural interventions, at the same time that they don't want modern medicine to intervene, that if you have a natural, normal birth, you should just let it unfold in a natural manner. And that was very challenging very early on to see that so much interventions were being done, but they were being called natural interventions. Often midwives confuse what the word skills mean. In my generation, we knew what skills meant. We learned breathing and relaxation. Now in Birthing Better, there are many more skills, broader and deeper range of them. And there are other skills-based methods, and you can explore those as well. But when we use the word birth skills now, nobody really knows. Look it up in Google and see what you come up with. But midwives use the word skills to mean, I have skills, I teach skills, I do skills. And their belief is that women then birth instinctively. And this is why I spent a number of years teaching Strengthening the Partnership workshop with a midwife who had gotten her family to work with our first resource from 2000 onwards, is that she shifted from what she did to what they could do for themselves. Childbirth educators are usually teaching their own associated method, although in New Zealand, when they're trained in Parent Center, they're generally trained and then they can choose what they want to teach, which is fine. None of the above really understood the concept. All of them were resistant, with the exception of obstetricians and those childbirth educators in the 70s that were teaching skills-based methods. The doulas believed that if women became skilled, they wouldn't need them, or they wouldn't need an obstetrician or a midwife. And that has nothing to do with it. That's just a projection of skilled women want professionals at their birth. And to have a doula and a skilled husband or other means that you have more than one person to help, so that you can trade off time and share a set of skills. Midwives would like women to be more proactive in pregnancy and birth, but they do that through lifestyle changes, like diet, stop smoking, exercise. But most women don't want to do that. However, the majority of women are fine with doing something very specific in the last 4 months of pregnancy from 24 weeks onward, because they now know birth is right around the corner. And learning skills makes sense to them for that one task that's ahead of them. The childbirth educators that are teaching information aren't as interested in skills. They are supporting the choice-based trend that got put in place in the 1980s. In some ways, it's hard to change society when providers are not motivated to do that. Women aren't going to rise up. But ICPA is uniquely positioned, as I said, because of the salutogenesis model. In their second degree, they're not primarily the birth provider. And they offer continuity of care well beyond even continuity of care midwifery. And they can lead a way to a new revitalized trend. And what will we see if we grow a self-learning skilled birthing population in terms of the 3 childbirth goals? We will see less suffering. And if we begin to include increasing body awareness and skills in pregnancy to open the body for birth, we are going to see easier recovery of the mother and the baby. And what Andrea, the midwife in New Zealand, saw was also a huge decrease in cesareans that were being performed because labor wasn't progressing, which is on the way to a stuck baby and long births. So we have a benefit. We just need to implement it. I've tried for 50 years, but I don't cut the mustard, do I? I'm not a midwife. I'm not a childbirth educator. I'm not a doula. I'm not a professional like you are. I'm not an obstetrician. I'm not a general practitioner. I'm not a pregnancy yoga teacher. I was just a body worker who happened to work with hundreds and hundreds of fathers and mothers who liked the idea, who craved the idea, who wanted to become skilled for their birth because their baby's birth was important to them. And they all knew that they had to do the activity of birthing their baby to get the baby out of their body one way or the other and into their arms. So I hope that you will work with me and as closely as you want. We can do this. And how quickly can cultures change? In my lifetime, it was 12 years between my first birth in the skills-based method and my second birth in the choice-based method. And that change occurred with the voice of a small group of dynamic people. ICPA can lead the way. Please join me. Let me guide you in this. And we can have a self-learning, skilled birthing population that spreads around the world.